grows to be significant costs. Let me give you an example of an interesting case that we did a little while ago. It's a 3-month-old female. She was diagnosed with tuberous sclerosis right at birth. She was noted to have seizures at 6 weeks of age, and then really became a catastrophic epilepsy. She was having 50 to 60 seizures per day. She was on multiple medications, and unfortunately, those seizures really never really abated. She had very little development during this time and a poor neurologic exam. You can see here on the imaging an abnormality, but her EEG localized to this left frontal region, but she had multiple tubers, but at least her EEG showed this very large hamartoma right in the left frontal region. I'm going to leave you at that, and I'm going to get back to it in just a bit, but just that's to set the stage, because there are big differences between adults and children with regards to the seizures and seizure types that we see. In adults, we often deal with the complex partial seizures of temporal lobe origin, usually mesiotemporal sclerosis. Children differ in that we often deal more often with a diffuse generalized seizure type. It's usually a cortical dysplasia. It can be extratemporal, and in those instances, like we saw in this particular case, that's not a small focus. They will often have numerous seizures per day, and unfortunately, a lot of their seizures will start to impact on their cognitive and behavioral development. This then has really long-term ramifications with regards to these children. Here's the incidence of epilepsy by age, and you can see sort of the early time period with regards to in childhood, but then extending up later as we age, older individuals who will develop epilepsy, whether due to post-stroke or tumor or trauma. But it's interesting when we look at refractory, at least when I was in training, we used to talk about refractory epilepsy being about 10%. But the reality is that it's much greater than that. When we see that patients, that about 50% of patients will be seizure-free with the first drug, pretty good percentage. But as we get into second drug and third drug, there's less and less likelihood that somebody is going to be seizure-free. The reality is that that about a third of patients will be unresponsive to medical therapy. That's a large percentage of patients that we probably were not identifying and or potentially even treating. So if we sort of think about this gap in refractory epilepsy, in the US, there's about a prevalence of about 3 million patients with epilepsy. That means that there's about 1 million patients in the United States with refractory seizures, but there's only about 3,000 epilepsy surgeries per year, the open cranial operations, and only about 4,000 neuromodulation procedures. So if we sort of think about this vast number for us to be able to catch up to, as well as all the new cases that keep sort of dumping into this pool, we have a large number of epilepsy surgeries that are not being done that really could potentially help patients out there. Our goal of epilepsy intervention, whatever it is, whether it be medical, diet, etc., is to stop the seizures. And so our goal with that is to prevent further brain injury or interference of normal brain function. And in particular in children, it's really allowing them to have more normal neural development. So seizures interfering with normal connectivity, normal development, but then also the very toxic levels of medication often lead to, again, delays in neural development, delays in connectivity, those kinds of things. Again, if you have a drug that its goal is to stop electrical connectivity and networks and seizures, doing that into a developing brain obviously has significant impact. So what's the goals of surgical intervention? It's the same exact thing. We want to stop the intractable seizures and give that child the best options for long-term development. With regards to epilepsy surgery, the best option for qualified candidates is to achieve a cure. So if we can identify a very focal area of seizure onset, those are going to be the patients that are going to do the best. So focal onset of seizures with a seizure focus in a region of cortex that's safe to remove, and in patients that are medically refractory, defined by the ILAE of 2 to 3, having failed 2 to 3 anti-epileptic drugs. And so very straightforward. And so it's amazing to me sometimes, maybe to also some of you, when I finally have a patient referred to me who had been on 10 drugs. And, you know, really at that point, when they're already 17 years of age, it's very, very difficult to reroute that course for that particular child or young adult. With regards to the surgical decision making, it's completely dependent on the seizure type. So it's important for us to identify and lateralize and then localize where the seizures are coming from. We can then consider whether a non-invasive evaluation or is an invasive evaluation necessary for us to obtain this concordance of data to be able to define that focality. And then obviously we want to look for a pathologic substrate, either lesional or non-lesional, and sort of work our ways from there. There's a lot of new technologies that have come out over the last number of years since I started training, and that's really been in this conceptually how to better localize the seizures. I won't belabor most of these, but the important things to point out is that in this day and age, anatomic imaging with improved MRI and unique sequences really does help us identify lesions that we could not see before. And as well, since epilepsy is a functional disorder, it is absolutely necessary to be able to incorporate functional imaging into the decision making. Now, there's a lot of different other technologies, and I won't belabor those, but again, if you focus on anatomic imaging and functional imaging, these are going to be really your mainstays in localization. There are a number of what we call phases for this evaluation and treatment. Phase 1 is considered the non-invasive, and it involves all the standard that I just somewhat mentioned. It's the history and semiology of the seizure type, EEG, which is a functional test, the video to be able to marry up the semiology and the electrical abnormalities, imaging, both anatomic and functional, as well as some of the other assessments, including neuropsychological, because you will already see where the developmental anomalies may be occurring. With regards to the non-invasive, at least the imaging parts, as I already mentioned, anatomic imaging and functional imaging are our mainstays. And then again, with the new development and new technologies of things like MEG and resting state fMRI, we now have an ability to marry some of these modalities of anatomic and functional imaging in order for us to be able to define abnormalities. So here, simple MRI on a patient, nothing really obvious on that particular study, but with further sequences, one can appreciate here in the insula abnormality with some cortical thickening and clearly a difference from the contralateral side. We can then put in obviously different sequences in different directions to be able to target these different areas potentially for our seizure treatment. Similarly with DTI, we would like to see the tractography to see, for example, in that insular lesion where there may be some important descending tracts, and so this helps with surgical decision making. With regards to functional imaging, there's a whole number of different functional imaging options, and again, depending on what's available to you, these become very useful particularly with very standard abnormalities that we deal with. Here's a patient with left temporal abnormality on PET. This is a hypometabolic study. So the glucose metabolism here in the left temporal lobe, very abnormal. This patient had concordant data with left mesiotemporal sclerosis as well as EEG pointing toward the left temporal lobe. But it can also be used in marrying up other technologies here using MRI and PET, and we can see a hypometabolic area in this patient in the right parietal region. With regards to SPECT, interictal SPECT, not a lot of sensitivity and specificity, but this uses blood flow to look at differences. This is an interictal SPECT scan. One can then also use ictal SPECT, so you can see the really hot area where blood flow really significantly increased after injection during a seizure. And then with new technologies, you can actually do a subtraction study with the background interictal and ictal studies and then be able to target this area. And then if you then marry on other technologies, now you all of a sudden have really great opportunity to have a targeted area that would be a potential surgical site. Functional MRI was originally developed as task-based, so you needed an awake patient. It looked at blood flow. In many instances, it's replaced the WADA test, being able to identify where motor cortex is, visual cortex, as well as language. But unfortunately, both WADAs and task-based fMRI are very difficult to do in children. Awake, alert, cooperative 3-year-old is absolutely impossible. So for that reason, I think that we're excited about resting state functional MRI. So this looks at, again, blood flow and looking at standard networks, and then looking for where there are some abnormal networks. And so again, if one looks at all the normal networks and then starts to look at things like here in resting state, picking out language areas, here left language versus right language, one can now start to appreciate the differences in being able to do this in patients who are asleep, but still have electrical activity to run the networks that are going on. Here was the resting state showing an abnormal functional network in the left temporal lobe. One can appreciate here the left temporal lobe abnormality that again localized to what was a left mesiotemporal sclerosis. Here was a patient with a tumor, and again, using resting state to identify where the seizure focus may be relative to this tumor. Here you can see the lesion and in the area here, and then with regards to the resting state, showing the resting state network here with the abnormality. And in fact, when we went in to this tumor, removed the lesion, but also focused on removing these areas, the patient was also rendered seizure-free. This is MEG, and again, not to belabor this, just an exciting technology. It's been around for a lot of years, but really because of its expense, it's very difficult to get and very difficult to use. But I think that hopefully in the future that this will be a useful technology for many more institutions. Here was a patient that I treated a number of years ago, 14-year-old with, interestingly, his EEG showed left frontal seizures, but he had this lesion back here in the parietal lobe. Here was his MEG, and you can appreciate the abnormality, the spread from really right around that lesion. And in fact, in that patient, we targeted that area and with SEEG and eventually treated him surgically. With regards to invasive monitoring, again, this requires a surgical implantation, and it's really when there's non-concordance of data. There's a lot of different options, and again, I won't belabor these, but whether one uses depth electrodes, SEEG, or surface electrodes, or a combination, the goal is to identify not just the seizure focus, but also where that seizure focus is relative to their functional areas. Here's a stereo EEG strategy for a more posterior extent. Again, lots of electrodes to try to determine the extent of seizures in this particular patient. Here again was that patient that I showed earlier with the MEG, and we did a very targeted SEEG strategy in him, and you can see the localization of the electrodes in this patient that all targeted really that area that we had seen on the MEG. And then here's the post-resection, again, a patient seizure-free after treatment. With regards to an insular lesion like this is much more difficult, and one really needs to have very targeted strategy. When you have a deep lesion like this, we do in an instance like this a combination of both depth and surface electrodes. Let's just use this as an example. Here's the lesion. We would use a strategy where we would place electrodes surround that area. Here's how it would look with regards to, let's say, the gyrus. And then here's just the open craniotomy with the electrodes in place around this lesion, and then using a surface electrode strategy also in combination to be able to really define these areas. We also still use cortical surface electrodes, again, when we're trying to identify areas of eloquent cortex, such as Wernicke's or Broca's in these instances. And now you've got seizure focus as well as a relationship to functional areas. Well, then moving on to surgical treatment options. It's been great, really being in the field over the last 20, 30 years. And again, part of that has been the ability for us to do more and more for these patients. There's lots of different options. And again, I won't belabor most of these. I'm just going to go through some of the basics. But again, marrying up your data to what would be the best option in a patient is really what the goals are for epilepsy surgery. With regards to the resective surgery, temporal lobectomy still remains the most common surgical procedure, both in adults. It's very common in children. And again, because it can be done safely with a very focal area of epilepsy, this has been the mainstay of what we've sort of dealt with over the years. There's a range of syndromes that can occur, and at least in the old days, we always put in depth electrodes and did invasive monitoring or surface electrodes. But now with improved anatomical and functional imaging, I would argue that for these days, most patients don't require so much invasive monitoring. It's only when there's a question of is there involvement with, let's say, frontal lobe or some other area. And again, depending on the pathology, one would then consider surgical intervention. Here is a patient, and you can appreciate the cortical dysplasia in this particular child, and then afterward, temporal lobectomy, and this patient did very well and was seizure-free. With regards to extratemporal sections, this is more common in children because of the dysplastic tissue that we often see in these patients. They do often require phase 2 evaluation, so the open or at least, invasive evaluations with either depth or surface electrodes. But again, imaging has really taken on really importance when it comes to developing your hypothesis of where the seizures are coming from. You can see here in this particular patient, with a schizencephaly. Here was their subtraction SPECT, showing this to be the hot area or expected area of seizures. Here was the surface electrode strategy in order to try to define where the seizures were coming from. Here's the post-op skull film, just showing the extent of those electrodes. When one looks at EEG, and you can appreciate on here, seizure onset, this really went to these, so the seizure onset you can see down here as well as here to be able to see where those electrodes were, and you can see how well it married up to the functional imaging. Cerebral hemispherectomy is what we would consider the ultimate focal resection. The goal is to stop the seizures in a patient who has a holohemispheric abnormality. Clearly, the secondary purpose is to allow the more functional hemisphere to improve. Again, I'm dating myself. Started with anatomical hemispherectomies, and now through the evolution of functional hemispherectomies and then disconnective procedures, hemispherotomies, and now there's individuals who are out there doing endoscopic hemispherotomies. I haven't yet challenged myself to do that, but having said that, I think that this has become, in this day and age, with the more gone from a very maximally invasive to a much more minimally invasive approach. This was the sort of the old functional hemispherectomy where we were trying to reduce the amount of resection for these patients in a smaller incision. Here was just a typical look of what things would look like afterward. And then with the evolution of hemispherotomy and doing, let's say, in this instance, frontal opercular or insular disconnection. And in fact, as I've mentioned, these cortical incisions have gotten smaller and smaller, and the ability to do these disconnections really has become very slick with some of the new technologies out there to be able to do these types of procedures. Just moving on then to disconnective procedures. Clearly the goal is to disconnect the abnormal focus from the normal functioning brain. The different types include corpus callosotomy, multiple subpial transections, which have had a mixed history, really because of the lack of significant efficacy in most patients, and then hemispherotomy. But you can also do disconnections, which I'll talk about a little bit later. For example, hypothalamic hamartoma, or in a case that I have this morning at 7 a.m., a disconnection of the temporal parietal and occipital lobes, doing a motor sparing disconnection in order to try to eliminate seizures from a more posterior extent. Callosotomy has been around a long time. Really, it's just about interrupting the commissural fibers between hemispheres. This particular surgical technique is really quite useful for patients with atonic seizures. It limits the interhemispheric secondary generalization, but remember, it rarely produces a seizure-free state because it's not taking out the seizure focus, it's just disconnecting basically the two hemispheres. Good results, though, for atonic seizures. This is just a typical surgical view that one might encounter. You can see what might be the extent of a craniotomy, though right now we do the craniotomy more to this level and then use the microscope to disconnect the corpus callosum. There are others who use endoscope through a much smaller incision, and again, I think with improved technologies in this regard, that this can be done more minimally invasive, as has already been shown. This is just a nice surgical view that we see. Here's the corpus callosum, genu up here, splenium posteriorly, and you can see with the microscope, one can appreciate here's the ependymal lining, and you can come right through the corpus callosum and leave the ventricles intact in order to get a very beautiful disconnection in these patients. With regards to hemispherotomy, again, simple disconnection. Again, and this is a much older picture at this time, but one can appreciate you can disconnect these areas and allow for at least decrease in the complications. This is an old series of mine, but again, with temporal lobectomy, you can appreciate we can get very good to excellent surgical outcomes. With some of the other lobar or extratemporal resections, a little less, but with hemispherectomy, good results can be gotten. With corpus callosotomy, again, for the right indications, when it comes to drop attacks, atonic seizures, you can get upwards of 70 to 100%, depending on the series you read, and again, depending on the individual seizure syndrome. And so again, depending on these patients, the better they're targeted, better, how should I say, the better the candidate for specific procedure, the better the outcomes for these patients. With regards to complications, not unusual. Again, with the hemispherectomy patients, oftentimes the concern is hydrocephalus. I think we see that a lot less now. I can't think of the last patient that we had to shunt with the new hemispherotomy techniques. So with regards to resective surgeries or disconnections, again, overall, one can get upwards of 90% seizure-free state, improved outcomes, again, depending on location, and mortality is much less with surgery as compared to continued intractable seizures. SUDEP remains a big problem, particularly in children. So going back to my original presentation, here again is this child. We did the surgery in the frontal lobe, resection of that abnormal area. We did a guided with electrocorticography. Patient was in the ICU for 1 day, regular room for 1 day, and then went home. This was postoperative day 2 for this child, and there were no seizures since surgery, and this was the first time the child smiled. The parents were obviously quite happy and crying, and but again, this shows when you identify the right patient and target the right area, you can have great outcomes. I think in this day and age, minimally invasive approaches are going to be our future, and I'll kind of breeze through these, but one of the areas we're excited about over the last few years is stereotactic laser ablation. And again, if you need a very targeted zone, while resection still is the gold standard for being able to treat these patients, I think now this really marries into the less invasive, can be better if we can target the right patients. Again, we consider them when there's this targeted area, and usually when there's a small area to ablate. We have a danger of being too precise, particularly in patients with cortical dysplasia, since epilepsy is a network disorder. And these are the things that you need to take into consideration when considering laser ablation. Again, it's a small incision. It can be quite targeted. We do placement of the laser probe. Thermometry is done in real time. And so in this way, you can identify a target and hopefully treat that. This has been particularly effective in patients with gelastic seizures. This is a 2.5-year-old. You can see here the hypothalamic hamartoma on these sequences here. This is just a representation of what you might see. Here's the laser probe down to target with the temperature in these different target zones. And then this is what you would see afterward on a DWI, diffusion weighted imaging with the edema pattern in this, this particular patient. And then also in a T1 with contrast, you can see the laser probe and the extent of the ablation in this patient. Laser ablation is also being done for other indications like mesotemporal sclerosis. So Here's an example of a temporal lobe with the initial heating anteriorly in the head of the hippocampus, and then do a series of pullbacks in order to ablate in a basically a cone-shaped manner the tissue along the tract. And so using image guidance to place the probe in the appropriate target with the appropriate trajectory, one can really obtain a nice ablation in this area. And we can do this for surface cortical dysplasias. Here was a patient with a deep sulcal and gyral cortical dysplasia. Here we used, actually, this is a single probe, but we've used multiple probes. For example, in this patient, here you can see 2 probes and the extent of the ablation to be able to achieve excision of this particular seizure focus. Just as an aside, we've also used it for brain tumors. This was a patient with a recurrent medulloblastoma. We were able to biopsy this area, confirm it, and then use ablation technology to remove it. With regards to neuromodulation, this is an exciting area that I think is really going to really have a boom when it comes to a lot of the patients who don't have a focal area to resect or ablate, but have multiple areas or multiple areas that are in eloquent areas of the brain. These would be areas that we could now target with our neuromodulation. And there are a number of different opportunities, and actually what I'm missing in here is focused ultrasound, which I also think will be in there as a potential future treatment. VNS has now been around for, I hate to age myself since I put them in when they first were approved, so 23 years now. They're not what we would consider surgery. We try to convince our neurologists, our epileptologists, that it's not really surgery, that it's just an implantable medication. And that's gotten some neurologists to get off and refer these patients appropriately. It is an implant, but the neurologist controls the frequency, the intensity, times of the day now with certain technologies. In some instances, there's somewhat of a modified closed loop system. So there's really great opportunity for patients for VNS. We use it in any child or adult who has medically refractory epilepsy. Greater than 2 AEDs have been tried when surgical resection or disconnection or not an option. So sometimes we'll marry these with, I'll do a corpus callosotomy and a VNS in the same procedure. Again, depends on the patient, the right patient for the right procedure. It's an outpatient procedure. This is a very old picture. You can tell by the device that was used. But in the reality is that the total case time is about an hour. They go home about an hour or 2 after surgery. 2 incisions, 1 on the neck and 1 on the chest. Here's an example of placement of the electrode wires on the vagus nerve, and then the implant at the level of the chest. There's a wonderful video of how I do this on the CNS, Congress of Neurological Surgeons Nexus website, really with an explanation if you're interested in this particular area. I believe that this is really an underused technology that's really has good outcomes for patients. This has just been the evolution of the different generations of VNS generators over the years, and now the much smaller device, the Sentiva, which can, as I mentioned, really can be programmed at different times of the day. So if seizures are more common at night versus during the day, you can actually program to have more stimulation at night versus the day. These are just some of the results from the long-term outcomes, and not bad results when you consider that about only 4% of patients are going to respond to a third anti-epileptic drug. Being able to get greater than 50% improvement in seizures over a long period of time is clearly a marked improvement for these patients. So I usually tell families that with VNS, about a third of patients will get a significant improvement, a third a so-so improvement, and a third they'll be the same without really any change. I have mentioned that patients with Lennox-Gastaut or have multiple seizure types, in those instances, we'll often marry the VNS with the callosotomy, sometimes at the same sitting, in order to do these. This is an old series of mine looking just at complications. And again, there are different alterations in voice depending on how close to the recurrent laryngeal patients have. They'll often complain of a tickle in their throat, but in the sense of actual vocal cord paralysis or paresis, very uncommon, usually resolves within about a month. This is an old series of mine, as you can see, but again, good results with very, very small complications. RNS has really come on the playing field with regards to our ability to offer new types of treatment for these patients. We've started putting them in about 2 years ago. Again, patients with frequent seizures, poorly controlled, but unfortunately in areas that are not resective. So bitemporal or in motor cortex or in those areas. It's often times for patients who are poorly controlled, but localized to a specific area of the brain. Again, it's in the United States, it's FDA approved for adults only, but we have put them in a 14-year-old, particularly a large 14-year-old who looked like an adult. But, you know, in these instances, really very good targeted treatment is really what's necessary. It's a series of electrodes that are either implanted in the brain or on the surface of the brain, with then the generator actually implanted in the skull. You can appreciate the sort of the design here and how it's done. And then it reads EEG, and then closed loop will give a stimulation once it's taught which seizure patterns to target. Here's an implantation. You can see the craniotomy to place the surface electrode, a depth electrode in the temporal lobe, and then the generator with the wires nearby in these patients. Here is another with a number of surface electrodes. And again, you can see the implantation into the cranial bone. You actually cut out a template to put the generator right into the skull. Good results have been reported by Morel and group. And I won't belabor this, but you know, clearly this was a double-blind study with on-off for patients, and you can see the significant difference when receiving stimulation. And this is just, I'll refer you to these articles by Berge and Geller in order to look at the long-term outcomes for these patients. So in summary, I know I've run through a lot in a very short period of time. I apologize. But the reality is that intractable seizures clearly impact mortality with SUDEP, morbidity, and clearly quality of life. And when it comes to children, it also impacts on their abilities to develop more normal function. We know that outcomes from surgery are better in select patients as compared to continued failed medical therapy. And I highlight that failed medical therapy because there are many, many patients that have failed medical therapy that are not being referred for surgical treatment. We know that surgery interrupts the seizure interference, whether due to medication or the electrical abnormalities. And we know that localization now with new technologies really does give us new opportunities for cure and clearly to improve the whole lives. This was a great story, and I love telling this story. This is a young woman who was 14 years old when she presented to me. She had classic right mesiotemporal sclerosis, right temporal lobe seizures. Her neurologist tried to talk her out of having surgery. Her parents didn't want her to have brain surgery. She came to us when she was 18 years old and 1 month, and she said, "I want the surgery." And she had her surgery, and a few months later, she did her marathon. So, and remained seizure-free, and now she's a special ed teacher. So with that, I can't do this without a team. You see that it's very labor intensive, and I couldn't do it without the group that I luckily have here at Barrow at Phoenix Children's. So with that, I thank you for your attention and appreciate the invitation to be here with you today.
Thank you so much, Professor Adelson. I think it's a brilliant presentation, a grand tour of epilepsy surgery. So we really thank you for all your experience. I guess in the interest of time, we'll move on to the next speaker, and then
Adrian, maybe we can take you can ask one or two questions from the chat.
Okay,
if you'd like. Yeah.
All right. So there is here a question from Dr. Wayan Arianta from Indonesia, who is asking if there is any memory loss after epilepsy surgery. I guess he's referring to temporal lobe.
Yeah, so I think that's what's been exciting about using laser ablation is that we feel that we can do more with less interruption or interference. Again, remember, we're looking at a diseased temporal lobe, so if they already have a damaged hippocampus that we see on imaging or functional imaging, let's say metabolically it's not functioning well and it's only causing seizures, many times these patients don't have any memory change because they've moved memory over to the other side. This is particularly true in children. If you've got a very diseased temporal lobe, many times that mesiotemporal structures and amygdala and mammillary bodies, fornices haven't really developed well, and so we don't see that kind of dysfunction. Now, in an acquired epilepsy or in a patient like who is an adult who with a more normal appearing imaging, then yeah, there is a significant risk for memory loss. That's why we do, or why we did why we did WADA testing, was to look if memory subsided in that area. We did have a patient where it looked like they had a diseased temporal lobe, but the reality was that there was significant memory in there, and we ended up putting in an RNS, the responsive neurostimulation. She's still seizing out of that area, but we couldn't afford to take that area because of her memory function.
So I guess one of the big lessons that we have learned over time is that we need to start operating on these kids at an earlier age, not to wait until we have generalized activity. There is another question here from Dr. Syed. He's basically asking if it's necessary to remove the complete amygdala whenever you're doing a amygdala hypocampectomy.
That's a tough question. I think that it's very difficult to not marry that they're too connected, and so I've not done a procedure where I left the amygdala and only took the hippocampus, or vice versa. The challenge has been is when I've had an amygdala tumor, and I'm trying to, and we know that seizures are coming from that area, but let's say it's left temporal lobe, I'll remove the amygdala and the tumor, but I'll try to leave the hippocampus, but many times those patients come back, they've already had their seizures kindled into that area, and it's those are very difficult to control. So I haven't been able to leave the amygdala and take just the hippocampus alone. They're usually connected, but I have taken the amygdala and tried to leave the hippocampus.
Another thing that I noted in the presentation is that we also started 20 years ago, and initially we would be doing partial callosotomies, and then we realized that kids would still continue to seize. So nowadays, for many years, I would say probably in the last 15 years, we do complete callosotomies, and we have not seen a clinical significant disconnection syndrome. Of course, many of these kids have intellectual impairment, but I still have to see that.
Yes, well, you're absolutely right. That's why I was smiling. I almost I do still about 75% complete calissotomies. Usually it's the neurologist talking me out of doing the complete because they want to preserve the patient has good language. But when you've got a child who's 8 years old and you do a complete calissotomy, they learn how to their behavior and their neurodevelopment allows them, they don't have a disconnection. They're using both sides, they're interacting with both sides, they're using other senses to allow them to coordinate their function. I think that was very true for maybe older individuals, but for children, especially children who are not developing language well, you should go right to a complete calissotomy right away.
Okay, I think, thank you, David. It's brilliant. We're going to move on. I request Mahmood Qureshi is here as well. Moody, are you there?
Yep. Great talk, David. Thank you very much. It was nice to see you and nice to hear your wonderful talk.
Nice to see you, Jim. Thank you. And thank you, Dr. Syed. Appreciate it. Adrian, good to see you. Take care, Salman.
Thank you. Thank you very much.
Okay, next online we have Dr. Hasan Syed, who's from the University of Virginia in Charlottesville in the USA. I haven't had the pleasure of meeting you, Syed, but hopefully we will in one of these Corona things goes away. But over to you. It's going to be nice listening to you talk on spinal dysraphism.
Thank you. Thank you, everyone, for having me. I really enjoyed the previous talk, and I'm looking forward to talking about the spinal dysraphism. It's something, as pediatric neurosurgeons we deal with, but also as adult neurosurgeons who have patients with these conditions. And so really, I wanted to go through the focus of this. There have been books written about this whole topic. So the focus of this talk, at least, will be to review the historical perspectives and the embryology of this condition. Really define what it is in terms of open and closed neural tube defects and discuss classifications, as well as comparing operative management techniques. So moving forward, I think it's always important to look at the historical aspects of what we're doing and where we're going. It sort of centers us and gives us a better understanding of the condition. So looking at spinal dysraphism, there's been descriptions really dating back to 10,000 BC in terms of these conditions, and you can see on the pictures to the right. These are actually from the collections of Dr. Goodrich of patients and kids who had this. And specifically, you can see the posturing that we see with the hands resting on the knees and the severe kyphosis, as well as the picture on the right, the association with hydrocephalus. Even Hippocrates described this condition, although the understanding of which was pretty limited. Moving forward, it wasn't really until 1610 that Peter Van Forest described the earliest surgical attempt for this condition. And his account was of a 2-year-old child with a neck malformation that appeared to have the form of spina bifida, and he surgically ligated this mass, but the child went on to die. It wasn't really until the 1640s when the Dutch anatomist Nicholas Tulp coined the term spina bifida and described what it was. And he described, I think, about 6 anatomical cases of a myelomeningocele. And in fact, one where he ligated the pedicle of the myelomeningocele and the patient died of an infection. And naturally, because of this and his experience, he recommended approaching these lesions with conservative treatment because of the consequences. Later on in the 1700s, the Italian anatomist Morgagni provided the first clear description of the association between hydrocephalus and spina bifida. And then the 19th century was really when we started to establish the pathologic understanding of this condition and the early anecdotal surgical reports. In the 1800s, the French anatomist and pathologist Jean Crouvellier broke new ground with detailed and colored information and illustrations, as you can see on the right. Again, early surgical intervention was associated with high mortality, probably also because of the risk of infection, and it wasn't really until the advent of the aseptic surgical procedures that perhaps the surgical complications decreased. Virchow, again, coined the term spina bifida occulta that we know today in association with tethered cord syndromes. Von Recklinghausen, in this picture on the right, described the association of spina bifida occulta and hypertrichosis. And then Johnson, who was a surgeon at Toronto, described the first case of a lipomyelomeningocele. But again, this child died 6 weeks after surgery because of peritonitis. So these were really noteworthy pioneering attempts for surgery, but again, the outcomes weren't that great, just given the medical and surgical conditions at the time. So the early and mid 20th century really focused on understanding and recognizing the signs and symptoms of this disorder, and also the first imaging and successful surgical series. The association with urinary, cutaneous, and orthopedic, as well as skeletal abnormalities with occult spinal dysraphism was discovered. And in the 1940s, Lichtenstein, who was a neuropathologist in Chicago, his work really provided the basis for the understanding of spina bifida occulta and tethered cord syndrome as a separate diagnosis without apparent signs of spinal dysraphism. The modern era, again, focused on improved diagnosis, imaging, and standards of care. In the 1930s, Charles Fraser, who was a neurosurgeon in Philadelphia, sort of devised and defined the methods of closing a myelomeningocele. Ingram and Hamlin in the 1940s reported 279 cases of myelomeningocele and officially wrote the techniques down. And other surgeons had similar experiences. As well, we learned that folic acid was critical in terms of preventing at least myelomeningoceles, and then also early diagnostic ultrasonograms provided a role in prenatal diagnoses. So really the historical path when we look at spinal dysraphism went from Tulip's advice against surgical management to what we have today in the modern era of prenatal diagnosis and even surgical management prenatally with fetoscopic surgery. And so we'll talk a little bit more about that, but the evolution of treatment really stems from our understanding of this condition, as well as the technology that we have in surgery. So looking first at the embryology, we know that the process of neurulation really describes when the neural tube forms, and the neural tube ends up becoming the central nervous system. And there's various factors that lead to the differentiation of the three germ cell layers, but the ectoderm, which is exposed to BMP4 from the endoderm and mesoderm below, really develops into the skin, but the node secretes antagonists to this, and that eventually develops into the nervous system and the nervous tissue. On the picture of the right, you can see the process of folding in terms of neurulation to the neural plate, and as the neural fold closes, the neural crest delaminates and migrates away and forms the peripheral nervous system. And then the closure happens first in the middle of the tube and then zips rostrally and caudally. In this picture, you can see that the failure of the neuropore to close can cause neural tube defects. We know that the anterior neuropore, which closes around day 25, failure of closure can lead to anencephaly. The posterior neuropore closes around day 28, and of course that can lead to myelomeningoceles. Looking at the embryogenesis of the spinal cord and its development, it really can be summarized into three stages: gastrulation, which is the conversion of the embryonic disc; primary neurulation, as we talked about, the formation of the neural plate to the neural tube; and then secondary neurulation, which occurs in weeks 5 to 6 occurs with a series of steps, including vacuolization, canalization, and retrogressive differentiation. And so the fate of the secondary neural tube really is to undergo this process that's not completely understood, but this forms the basis of the tip of the conus and the filum terminale. Again, secondary neurulation can lead to other types of spinal dysraphism disorders that we can talk about in a bit. So what is spinal dysraphism? Really a general term or general definition is a midline fusion defect of the bone, skin, spinal column, or the spinal cord. And when we think about the classification system, sometimes it can get confusing because there's so many different diagnoses. But if you think about the pathology behind it and whether it's an open neural tube defect or a closed neural tube defect, that really helps in sort of classifying these conditions. And so, as we know, the majority of spinal dysraphism, at least open, is myelomeningoceles, and we'll go through that shortly. The closed spinal dysraphism can be subclassified into those that have a subcutaneous mass, which one of the common ones are lipomyelomeningoceles or terminal myelocystoceles, and then those without subcutaneous masses. And that can be a whole range of pathology, including split cord syndrome, dermal sinus tracts, spinal lipomas, fatty filums, and so on. And so we'll talk a little bit about that as well. So myelomeningoceles, at least in the US, early on, the incidence was about 2,500 to 6,000 births per year. And as we talked about, this results from a failure of the caudal neural tube closure during primary neurulation. And these babies are, associated with Chiari-2 malformation, which essentially leads to a small posterior fossa, a descended brainstem, as well as cerebellar tonsils and tectal beaking, which can be seen in imaging studies. And McClone, who was in Chicago, notably discussed the unified theory of this condition in these patients. And the fact that the Chiari-2 malformation, is resulting from the loss of spinal fluid from the open myelomeningocele. As we know, hydrocephalus can be associated in upwards of 80% of patients. 85% are located caudal to the thoracolumbar spine, and it's associated with folate deficiency. So risk factors leading to this condition can be a history of a pregnancy with a prior neural tube defect, that can be up to 3%, a partner with a similar condition. Other things that can be associated with are, history in the mother of diabetes mellitus, seizure disorders, specifically taking valproic acid, obesity. Of course, there's non-medical issues that can be associated with myelomeningocele, including exposure to pesticides, cleaning solvents, radiation exposure, and so on. So looking at prenatal diagnoses, the maternal AFP value is critical. The initial screening is optimal timing is done between 16 and 18 weeks. In the amniotic fluid, AFP concentration is usually 100-fold less than fetal CSF. But it's important to also note that a false positive can be seen in incorrect gestational age, multiple pregnancy, fetal demise, and other conditions as well. Ultrasound can be used for prenatal diagnosis. Its sensitivity is quite high. Hydrocephalus and Chiari-2 malformations can be seen as well. We'll look at some of those signs, including the lemon sign, which is the scalping of the frontal bones that is present in the majority of fetuses, as well as the banana sign, which is an elongated cerebellum and an abnormally shaped midbrain. The fetal MRI can be used as well to look at detailed anatomy and location, as well as associated findings. Oftentimes, at least here in the US, it's used to further define the lesion and counsel parents in terms of, what neurological deficits can be seen. So on the left, you see an ultrasound of the lemon sign. You can see how the frontal bones are sort of pinched in, and the banana sign on the right, you can see here. These are just pictures of fetal MRIs of patients that I've seen myself, and some of the defects that can be seen here on the left, and then the Chiari-2 malformation with the descended cerebellum and the small posterior fossa, as well as a sagittal view of the child with this myelomeningocele here. And this is another axial view of that child. So as again, these are things that we know, but the signs and symptoms include a lower extremity weakness. The myelomeningocele can be ruptured or unruptured, associated with urinary incontinence and skeletal abnormalities as well. Management of these patients, these kids, you know, if it's open, or usually in most cases, AMP and gentamicin are used for antibiotics. The child is kept prone. Telfa with wet gauze over the lesion to keep it from drying. Surgical closure is usually done within the first 2 days of life. You know, we'll talk about shunting and treatment of hydrocephalus as well, but that's a consideration, early versus late. And then all the other non-neurosurgical issues that have to be taken into consideration in the care of these patients, including renal issues, urologic conditions, orthopedic conditions, and so on. You know, there's many different faces or pictures of myelomeningocele. You can see here, some are small, others are larger with the myelomeningocele sac. This is a child that, one of the kids that I closed. Some are larger. Oftentimes they can be closed very easily, but in certain cases, plastic surgery is needed as well. This is a case of mine here, a thoracolumbar myelomeningocele with a kyphus deformity. And you can even see on the picture to the right, even after drilling some of the bone down, it can you know, play a role in terms of wound healing as well. But really, the rate of hydrocephalus in these patients is related to the Chiari-2 severity, and the Chiari-2 severity is related to the location of the lesion. Obviously, sacral lesions have a lower chance of hydrocephalus, while thoracolumbar lesions have a higher chance of hydrocephalus. So very briefly, discussing the myelomeningocele repair, the way that I look at it, it's sort of an open book essentially, and the goal of surgery is to close that book as it is in normal kids. And so you can see here on the diagram that really the junctional zone is cut in order to dissect out the neuroplacode. The neuroplacode is eventually, you know, there are certain individuals, certain surgeons who will imbricate it and close it. The thought is that can prevent or reduce the chances of tethering, or when a retethering surgery is needed. The scar tissue is really focused in that area. And then finally, dura is dissected off, closed, and then the skin. And so these are some pictures of that. You can see the neuroplacode closing, then finally the dura is dissected and closed in a watertight fashion, and then the skin itself. There's some surgeons who also will cut the fascia over it and cover that as well. And that's certainly a technique too. So surgical repair often leads to scarring that may need untethering in the future. It's important to note that whenever you get a scan, radiologically, it's always lower and always considered tethered, but a tethered cord really is a clinical diagnosis. And the average time between tethered cord release operations is about 7 years. It's important to also note that shunt malfunction can mimic a tethered cord syndrome, as well as Chiari-related compression. So it's important to look at you know, patients who have had this condition and have a shunt, or if there's concern for hydrocephalus. So usually clinical care is dominated by the shunt and tethered cord problems, but you know, many patients, about 75 to 80%, you know, end up having a normal IQ. And hydrocephalus and shunt issues really tend to affect intelligence in the long run. So I think, you know, it's important to also discuss intrauterine myelomeningocele closure. We know from the management of the myelomeningocele study, or the MOMS trial, there were about 183 randomized patients in 3 centers, and they looked at outcomes postnatally versus prenatally. And you can see here that the chance of needing a shunt and a severe Chiari-2 or the presence of Chiari-2 is decreased in prenatal closure versus postnatal closure. Ambulation is increased, but the risk to the mother is slightly increased in prenatal closure. So that's also important to note. And at least here, where centers that offer it, I think it's very reasonable to consider this. And so looking at hydrocephalus in this patient population, I think what also comes to mind is whether an ETV can be done versus a shunt, and there's different techniques in terms of ETV, whether you use a rigid scope or a flexible scope, choroid plexus cauterization with it, and the amount of choroid plexus that's cauterized is also considered. If you look at the original published papers in the literature, you can see that that the patients who had ETVs associated with a shunt or ETVs with choroid plexus cauterization seemingly had a higher success rate compared to shunts. The neurocognitive outcomes are really still unknown. Oftentimes we look at scans and the size of the ventricles in patients who have ETVs versus shunts, and that sort of questions our mind in terms of what the neurocognitive implications are. I don't think that there's an answer for that, but that's something in the long run to look at as well. But certainly ETV is an option to treat patients in this condition with hydrocephalus. And so this is a myelomeningocele patient that I was taking care of. I tend to watch these kids and instead of doing treatment of hydrocephalus or the enlarged ventricles early on, I wait. This was a child who ended up needing a shunt for clinical reasons. And usually I will end up using a flexible scope and also doing choroid plexus cauterization. But I always plan to do this and position the patient as if they're needing a shunt in case an ETV can't be done. Certainly there's anatomical considerations, looking at the MRI, the thickness of the floor, the anatomy of the third ventricle to see whether or not it's possible. These are just some pictures from Dr. Worf and some of his publications looking at the floor of the third ventricle and the Bugbee wire being used to do the ostomy, as well as cauterizing the choroid plexus. So, I think as neurosurgeons, it's also important for us. There really is no organized group other than neurosurgeons that can really speak authoritatively on myelomeningocele patients, as well as the importance of folate and fortification to prevent this. And so this is something that we should keep pushing just within our community, as well as our patients and our referring physicians. A multitude of studies have confirmed that folate supplementation, about 400 micrograms per day, can result in significant reduction in neural tube defects. Here in America, decreased by 72%. And you can see this map on the bottom right that globally, we can do more in terms of mandating or voluntarily fortifying, foods in order to increase folate consumption. And this is something that Dr. Blount, pediatric neurosurgeon in Alabama, has really discussed as well. So moving forward from open spinal dysraphism to closed spinal dysraphism, I want to next talk about lipomyelomeningoceles. And as we talked about, this was first described in the mid-1800s, and the official term was coined in 1971. It occurs in 1 in 4,000 births in the U.S. With a female predominance. Truthfully, lipomyelomeningocele is a misleading term. It really implies a herniation of neural elements through a defect. But there's also subcutaneous lipoma mass that protrudes through these bony defects. And the neural elements actually remain in the spinal canal. And then there's an epithelialized skin layer overlying this mass. And so there's three types, the dorsal type, caudal type, and the transitional type. The transitional type being a little more challenging in terms of surgery and identifying the nerve roots coming from this mass. There's many cutaneous manifestations that are associated with this. One of the more original papers described the soft tissue mass in the majority of this, skin dimpling, hemangiomas, less commonly hypertrichosis, and other dermal sinus hypopigmentation. You can see some of those manifestations on the pictures to the right. Symptoms, again, can be related to cutaneous manifestations and other signs related to spinal dysraphism, including muscle weakness, muscle atrophy, foot deformities, and back pain. The evaluation, if this is discovered prenatally, maternal AFP is not really reliable in terms of closed defects. So ultrasounds can be used, and MRI is really the study of choice to understand this. And of course, urodynamic studies to establish a baseline to see if there's a neurogenic bladder can help guide the management as well as treatment. So you can see a picture on the right, in the middle picture, the T1 brightness of the lipoma, as well as the fatty fibrous stalk that goes up to the skin as well. So operative indications really are to prevent progressive neurological and orthopedic as well as urological decline, and to also prevent the development of new deficits due to tethered cord syndrome. So the goals of the surgery really are to detach the spinal cord from the tethering structures and to decompress the intramedullary mass and the fat. This can be done either sharply or, I will tend to use a CO2 laser as well to burn the fat, and then reconstruct the spinal cord and the dural sac as well. Moving on from lipomyelomeningocele to split cord malformations, this is really interesting and something that I didn't see in my training, but I'm seeing more in practice, both in kids as well as in adults, because I treat the spectrum, and it's certainly interesting to see patients who had been treated in the past, as well as those who were never treated, and they have some symptoms related to back pain or numbness, and they're found to have this at an elder age. And it's really interesting to me to talk about their symptoms to see whether surgery is something that would be beneficial if their symptoms are so severe. But in a lot of these cases, I have found that patients are okay with the symptoms they have and don't want surgery. But to talk more about split cord malformation, this was described in the literature, at least as early as the 17th century. It's extremely rare. The peak age really of discovery is 4 to 7 years and 12 to 16 years at the time of growth. And it's attributed to a single error in embryogenesis related to the adhesion between the ectoderm and the endoderm, leading to persistent neuroenteric canal. And historically, the terms have been described are diastematomyelia, which is Greek for clefted medulla. And so there are two types. The first type you can see on the picture are when the two hemichords have two distinct dural sleeves separated by a midline bony spur. And you can see this on the MRI, and typically these are located in the lumbar region. The second type is a split spinal cord in one dural sleeve, but the hemichords are separated by a fibrous band of tissue, and this can occur anywhere within the spinal axis. There's definitely clinical signs and symptoms associated with this condition. Most commonly is back pain, followed by neurological deficits that are progressive, urinary retention, and leg pain. There can be cutaneous markers as well, hypertrichosis, a dermal sinus tract, and a subcutaneous lipoma being the more common ones. Abnormal urodynamics can be seen in up to 75% of patients, as well as leg length discrepancy as well. So associated anomalies can be scoliosis, thickened phylum, syrinx, and other conditions as well. The surgical management really principally is to, when you look at the steps in surgery, is to untether the spinal cord and the associated tethering anomalies, which can include a sinus tract, a fatty phylum, and a terminal lipoma. And outcomes in this study, at least in the 1990s, the most significant thing to improve is pain, followed by sensory deficits and then motor issues. So this was a 2-year-old boy who was unable to walk by this age. And when he was scanned, you can see these axial images showing the split cord as you go along. And then also this bony septum here on the right side. And then the spinal cord kind of going back to one unit and tapering off. So these are the intraoperative images of that, and you can see here at the bottom the bony spur, and then the split cords, and then as it tapers down the phylum. So when treating these surgically, it's very important, as we talked about, to release all the tethering components. So the first thing you want to do is take down the bony spur and then cut the phylum, because as you can imagine, if you cut the phylum and this spinal cord is under traction, then it will cause traction from the bony spur as well as it's released. So that's critical in terms of treating this condition. So moving forward to terminal myelocystoceles, this is something that I found very interesting because there was a heavy population that was treated during my fellowship in Chicago. Just talking briefly about this, a terminal myelocystocele is a rare form of spinal dysraphism. It constitutes only about 5% of skin-covered spina bifida cases. And it's when a hydromyelic caudal spinal cord and a subarachnoid space herniate through a posterior spinal defect. And this condition can be associated commonly with cloacal anomalies, including omphalocele, bladder extratrophy, ambiguous genitalia, and perforate anus. So it's important to note that as well. And this is a drawing of it from Dr. Pang's article in 2012. Sort of, you can see the neural arch defect, the low-lying conus, and then the non-functioning wall and the cyst cavity as well. So as we talked about, the myelocystocele really consists of a skin-covered defect of the neural elements. It's arachnoid-lined meningocele that is directly continuous to a spinal subarachnoid space, and then a low-lying spinal cord that traverses the myelomeningocele and then expands into a large terminal cyst. There's many thoughts into the pathophysiology of this, which I won't go into detail, but some people feel like it's related to the CSF not being able to drain properly. Others talk about the dehiscence of the cloacal membrane leading to this function. And then others talk about it being a condition related to secondary neurulation. So when I was in Chicago, I ended up looking at, because there was a big population of these patients, looking at sort of the long-term outcome for these patients, related to ambulatory status, urinary incontinence, and the need for reoperation. And what we found were 55 patients, 22 male and 33 female, that were identified and treated with this condition, with a follow-up of about 12 years, 1 to 27 years. And you can see the majority of these cases were operated in the 1990s and 2000s. And then we separated these patients in those that had cloacal anomalies and those that did not have cloacal anomalies. And so you can see here that the mean age was about 9.2, and the number of untethering procedures most commonly was 1, but in one patient up to 4. And so this is just a diagram kind of splitting these patients. 62% had non-cloacal anomalies, and 38% had cloacal anomalies. And of those that did not have cloacal anomalies, the majority had some form of cutaneous manifestation that led to the diagnosis. And so you can see here that also included fatty mass, lipoma, but others less commonly included skin tags, dimples, and hemangiomas. In terms of surgical complications postoperatively related to this, most commonly was CSF leak followed by wound dehiscence and infection. But the long-term, when you look at the long-term clinical outcomes of urinary incontinence, again, the non-cloacal group had better outcome. 43% were continent of urine versus 5%. And in terms of ambulatory status, 97% of the non-cloacal group were ambulatory compared to only 71% of the cloacal group. So, what we found was that the myelocystoceles without these anomalies, cloacal anomalies, had a better long-term urological and ambulatory outcome, and that surgery, it results in a relatively low, but significant incidence of complications. So that's something to note when treating this. And you can see the pictures towards the bottom, what that looks like surgically, and it's very interesting anatomy. So moving on to spinal dermal sinus tracts. The incidence of this is 1 in 1,500, at least in the US, and this results from a failure of the cutaneous ectoderm to separate from the neuroectoderm. And it's usually identified when you see it above the gluteal cleft. And it can be connected to muscle, bone, dura, or spinal cord. And the reason that we worry about these conditions is the potential for intradural infections, including meningitis and abscesses. They can also possess dermal tumors, dermoid tumors. And so that's why it's also important to look into this. So this was a patient treated here, a 6-month-old girl with a lumbosacral dimple. You can see above the gluteal cleft and a cutaneous hemangioma. And the MRI on the right shows this tract that goes into the spinal canal and leads to a fatty phylum. So this patient was operated on at about 1 year of age, and we resected the dermal sinus tract and sectioned the phylum. And you can see the intraoperative pictures here of the laminoplasty between L2 to 4, and that tract was followed all the way in, connecting to the dura. The dura was opened and the phylum was cut. The post-op images show some residual fat near the end of the conus as well. So moving on towards fatty phylums. This is also something that can be controversial, or at least different opinions of whether or not to do surgery. But to talk a little bit more about fatty phylums, this is a viscoelastic band that fixates the end of the cord and decreases movement in the canal. It also allows the distal part of the cord to move slightly. And the thought is that caudal tension may result because of abnormal thickening. And this traction leads to some form of hypoxia that irritates the spinal cord and leads to certain conditions or symptoms at least. The fatty phylum term was coined in 1953, and then in the 1950s and 70s, there were surgeons who termed this in relation to tethered cord syndrome and advocated for surgery. So symptoms, just like other conditions, can be related to back pain, incontinence, numbness, weakness. And in terms of the MRI findings, a low-lying spinal cord, a fatty infiltration of the thickened phylum can be seen that's greater than 3 millimeters, and then also a drawn-out appearance of the conus as well. So the treatment of this is fairly straightforward if this is seen. And the workup, includes a good neurological exam as well as urodynamic studies to see if there's any objective, findings of an abnormal bladder. But really is exposing the phylum and sectioning it. Typically, neuromonitoring is used to identify, nerve roots and then the phylum, which can be done safely. So this was a child, an 11-year-old, who presented with persistent lumbar back pain and was noted to have a fatty phylum. And so I just want to shortly just show this video. There's the same principles of spinal surgery, using tubular retractors can be also employed in pediatric neurosurgery as well. And so this is a 20 millimeter tube with the dura exposed, and we ended up, I'm going to try to forward this a little bit, but we basically exposed the phylum in a very small durotomy, and you can see that here, the nerve hook, and then stimulating it to feel confident that this is the phylum, and then finally cutting it. Oftentimes people talk about closure through the tube. We use these anasta clips that can be used to quickly close the dura, but certainly it can be primarily closed with sutures as well too. A little challenging, but certainly can be done. I'd like to just end on this. This is an interesting case of caudal appendages. So, this has been described as like a human tail versus a pseudo tail. It's really an embryologic remnant that regresses between the 7th and the 8th week of gestation. It usually contains fat, muscles, and nerves that's covered in skin. And so a picture of this here, you can see But the principles of surgery are similar. It's to follow this tract all the way down and see if there's a connection to the dura, and then to the conus or the phylum as well. And so you can see these pictures here kind of demonstrating that, and then it's sectioned and removed. So the principles really are the same in terms of treating conditions with tethered cords. That's it. I'm happy to answer any questions that you guys have.
Lukman, you had a question. Do you want to? Can somebody unmute Lukman? He had a question. He didn't put it on the chat, so. Lukman Haider.
So thank you, Dr. Syed. That was a brilliant presentation. And of course, it is evident that coming from the Chicago school, spinal dysraphism is a must. And we really have to advocate for folate fortification worldwide in order to prevent these from happening. Let's look at the questions. If someone has one, please, you can post it on the chat.
Lukman, you're unmuted. If you want to ask, you can ask the question. I think it's probably a mistake.
Adrian, you also trained in Chicago as well.
I did, yes, under Dr. McClone.
Yeah. So I mean, yeah, the stories I hear about him and the experience from him is really amazing.
Yes, one of the most interesting things in the meantime, a few weeks ago we had this seminar on folate fortification at the ISBN Clash of the Titans. But one of the most interesting facts that I learned from him was that initially the term that was used, did you know why folic acid was changed to folate? Basically, as they were coming out of the 70s, there was this culture of, the hippie culture. Yeah. And people, women would avoid to take any acid because they were concerned that this acid would hurt their baby in the womb. So that's why the term folic acid was changed to folate. Mm-hmm. So all of these are the stories that Dr. McClone coins for. He's a true champion in the prevention. So we have here a question from Dr. Durdur that says, what are you doing for Chiari-2 with myelomeningocele?
Yeah, so that's a great question. Chiari-2 obviously associated with myelomeningoceles, and the question is whether or not surgery is needed for that. At least in my training and here, I haven't had to decompress a Chiari-2. Certainly reasons to do that if there are brainstem issues, with apnea, difficulty swallowing, dysphagia, things like that. When you look at the literature, I think most recently what I've seen is about 7 to 10% of patients who've had myelomeningoceles require some form of decompression. But I think it's less common. But I'm also interested in hearing, Salman and Adrian's opinion on that as well.
I will just let you know, we looked at our data, and as you know, Costa Rica has led the path in terms of folate fortification worldwide. We have the lowest rate, and I can clearly tell you that in the past 20 years or so, perhaps 3 patients have required a Chiari decompression at birth. It's almost now unseen. So this is one of the long-term effects of folate fortification. And what we know as a fact is that most of these kids that will require decompression of a Chiari at birth, they will have what Dr. McClone described as the unified theory. So the brainstem is malformed, the cranial nuclei are not well wired, and most of these children, regardless of the decompression, will continue to have long-term swallowing issues, and most of them will keep on having tracheostomy.
Yeah. Well, Robin Bowman, when I was there, she would always use the term small house, faulty wiring for this condition. Small house being the small posterior fossa, and then, as you mentioned, some of the neurologic issues.
I think we have the same experience as well. The only thing that we are seeing more and more is that, if they come in with hydro, I think we would go with ETV first and see if that would work, and that would take care of the KRE. And many times it does, yeah.
Yeah, with regards to, I saw there's one question on the chat in terms of hydrocephalus and treatment of that, or the timing of that. I think, probably in the past, it was much more common to be aggressive and treat the hydrocephalus or the large ventricles or what have you initially, and shunt the child even at the same time of doing the myelomeningocele repair. I think it's less common now, or at least what I've been doing is waiting and seeing if it really declares itself to treat, and then doing an ETV CPC first, and if that doesn't work, a shunt.
Okay, we have Ridab who wants to ask a question. I'm going to unmute Ridab and see if she wants to ask here. Yes, Ridab, please go on. Tell us where you're from, and then you can continue.
Thank you. Thank you, Dr. Hasan, for the great presentation, and it's very well informative. Sorry for the background noise because I'm in a public place. I just want to make it brief for you. In your series for the split cord malformation and the spinal dysraphism, in general, can you specify specific race in which those congenital anomalies are being predominant, like those with Caucasian descent or European descent? Did you find any difference in the races between these children, or it was global issue?
So, sorry, you were cutting off a little bit, but if I understand your question correctly, you were asking in terms of what races are more likely to have these conditions. Yeah. So with myelomeningocele, it's more common, or less common in African descent, and more commonly in Europeans and Caucasians is what I've seen.
Okay, good. There's Adrian, do you want to take more questions here? Moody?
Okay. Yeah. So there is a question here from Dr. Ali, which says, what is the recommended follow-up period of BP shunt after myelomeningocele repair, and at what age BP shunt can be removed safely?
So in terms of follow-up for these patients, or the patients with myelomeningocele repair, I mean, you really are forming a relationship and a bond with the child and the family for really life. And especially early on, once myelomeningocele was repaired, I tend to follow these patients pretty frequently, every couple of weeks, and then a month, 2 months, 3 months, measuring their head circumference, seeing their fontanelle, and even going as far as doing imaging studies, whether it's a head ultrasound or, we have fast MRI sequences, T2-based sequence to look at the ventricles. And so, at any period in time, especially within the first year, a shunt could be needed, and or treatment of hydrocephalus could be needed, and that's why it's important to follow these patients. If a shunt is placed, you asked about removing it safely. These kids end up being, very shunt dependent, and a lot of the symptoms, or if children have symptoms, I've seen symptoms that I wouldn't necessarily think are related to shunt malfunction in these kids. And sometimes you just have to bite the bullet and do a shunt interrogation or a revision. And so I don't think that there's ever a chance that a shunt can be removed, at least in my opinion or experience.
We did a study on these kids as we are following them throughout the years, and we found out that a significant portion of them will return to spina bifida clinic with a shunt which is functioning marginally or non-functioning, and the kid seems to be fine. But when you go ahead and revise that shunt in terms of performing an ETV or a shunt revision, a significant number of them will have increased ICP. So it's always good to look out for poor school performance, lack of play, and all of those subtle signs. Some of these kids will even have, because the lamina cruciform is still not closed, they will have swelling of their eyelids or nasal congestion. So it's challenging, but you should be able to have always on the top of your head that a shunt can be an issue.
Okay, brilliant. I think we can look at the multiple choice questions. I think both talks were brilliant. Really enjoyed that. The moderators really played their role. I don't know, Moody is probably still sleeping, although Adrian should be sleeping. It's early in the morning there. Moody, wake up. You have to unmute yourself.
Yeah, great talks. I think I wasn't sleeping. I was concentrating on the brilliant talks. Absolutely brilliant discussion as well.
Okay,
so
Hasan can take this, and then maybe you can take David's multiple choice questions. Yes,
sure.
Hasan, go on.
So the first question is, which disorder is a disease of primary neurulation? We talked about how a myelomeningocele is the answer, and that is the disease of primary neurulation.
Can you show us the answers directly, Imad, please? Thank you.
Okay. Yeah, and it looks like the majority of people did answer that correctly. The second question, what are...
Sorry, can you enlarge this? Just enlarge this. So that everybody can read. Yeah, thank you. Very good.
The second question is, what are the advantages of fetal repair of myelomeningocele versus postnatal repair? And we talked about how there's a decreased placement of shunts, decreased KRE2 malformation, and a decreased criteria for shunting, and all of the above. And so that's the correct answer, which the majority looks like answered correctly. The third question, the incidence of myelomeningocele has decreased during the recent decades. One reason for this decline may be the recommendation by physicians and OBGYNs for women to supplement their folic acid intake. What is the supplementation guideline to all women? And the answer to that is 400 micrograms every day. The fourth question, in an 8-year-old child with a history of myelomeningocele who presents with progressive back pain, scoliosis, right calf numbness, right leg weakness, incontinence, and bladder spasticity, which one of her symptoms is most likely to improve following a third untethering procedure? So we got more of a range of answers. The correct answer is actually D, back pain. So in these patients, back pain is one symptom that is most likely to improve, followed by some weakness and numbness. And so that's important to note as well. That's important to note when you're counseling patients and their families too, in terms of expectations from surgery. The fifth question is, which stage of diastematomyelia repair should be performed first? And we talked about how drilling down the spur is very critical before cutting the phylum. So the answer is B.
Moody, that's for you.
Fine. So, right. The first question is, corpus callosotomy is most often indicated for. So that's the overview that was provided. I think the answer that David gave was A, right?
Hasan has to give this answer.
Do you guys have the answers out of curiosity?
Yeah, I do.
I thought maybe it's complex partial seizures with secondary generalization.
Okay, one second.
Salman, did he not leave you with the answers?
I have the answers here. One second. I don't know where they are. So David had written to me, I'm online waiting. So that was earlier. Let's see.
There we go. It's D. Okay, complex partial seizures with secondary generalization. You've got the answers, Salman. You go ahead.
I don't have the answers. I don't know. They were somewhere in my mails, but I can't find them now. But no worries. Okay.
Okay, so the vagal nerve stimulation is most often indicated for
Obviously for
let's see.
So atonic seizures. Yep. Okay. Adrian disappeared on us when we were asking questions. Adrian, wake up.
The best results for epilepsy surgery are when the seizure origin is found in, I would think the temporal. Yeah, I think most folks got that.
Okay.
Pathology most often found in children with intractable seizures, I would imagine is B.
Cortical dysplasia.
Or
It is cortical dysplasia.
It is cortical dysplasia. That's what he gave his rundown. Yes, I agree. So guys, I think we are learning here as well. Thank you. It was brilliant. Matt, can you show us what we have for whenever? Okay, so we have a spine session and we have endoscopic lateral lesion surgery. So it's actually a WFNS spine committee thing in which Nicola Peeve and Shazad will be moderators, and arthroplasty, Oscar Elvis is going to be talking from Porto. And next. And then we have roton neuroanatomy session. So on Sunday, we have the session 3 of the module 3, which is cranial nerves 9 to 12. And we have Pablo Gonzalez and Professor Ahmad Kanan, along with Vlad Beniz, Azam, and Deo Pujari, who will be going through this. So it's going to be another fun day on Sunday. That's it. I think it's 4 o'clock. Okay. And Salim of the Roof is back, and he's going to be talking about awake brain surgery tips and tricks. And Athar Naam from Karachi will be showing some cases. Moderator would be Vlad Beniz. And this is for Monday. Yes, I think that's it. Yeah, that's it. Brilliant. I'd really like to thank the moderators, everybody, and just a few words from everybody before we wrap up. Start with you, Adrian.
So thank you so much for this opportunity. I think it's of great value to everyone. Dr. Adelson had to leave, but really like to thank him. Also, Dr. Syed for making this huge effort. And from all of us, thank you from Costa Rica, and please keep on joining these terrific sessions of learning for everyone.
Moody?
Great stuff, Salman. I think once again, brilliant talks by real experts. And although we seem to think that we do a fair number of spina bifidas here in East Africa, had a lot to learn from Syed. Thank you very much, Syed. That was a brilliant overview.
Thank you.
We loved it. And I'm sure all the folks from the countries which see a lot of this must have benefited a lot. Thanks again.
Thank you, Hasan. It was really informative. Really grateful to everybody who participated, and we will see you soon again. Okay, thank you. Bye-bye.